Thank you so much for that introduction. All right, let me get straight into it. So today I'm going to talk about the impact of Medicare's introduction on life expectancy. This is joint work with Andrew Goodman-Bacon, who's at the Minneapolis Fed, Joe Price, who's at BYU, and Daha Yue, who's at the School of Public Health in Maryland, and he was a former student of mine. I'm very excited to present this, and I should say this is the first time I present this. Well, I hope to finish. Be patient with me, and I'd be happy to take questions, although I understand that you save the questions till the end in here. So this is very preliminary and incomplete, so please don't cite this or post it or Instagram it or anything else like that just yet. All right, so maybe I don't have to convince people here about this, but I'm going to give my pitch. The big question we're looking at is whether Medicare saves lives. In case you don't know, Medicare is the primary health insurance program provided to individuals over the age of 65 in the United States. It's a federal program. And it covers today about 62 million Americans. It costs about $1,000 billion every year. So it's a very big item in the government's budget. It accounts for about 21% of health expenditures, 12% of all federal spending, and 3.7% of GDP. So I think it's easy to say this is one of the largest items in the budget. It is a very popular program among seniors, and as a result, it has been at various points suggested that it should be considered as a blueprint for a national health insurance program in the United States. On the other hand, it is a very expensive program, and because of that, it's considered for cuts constantly by various administrations. And so the purpose of this work is to look at what the benefits of Medicare are, and we're going to focus on the life extensions, whether there are any, and we're going to try to quantify those. And you might think that this is already well known and solved, but in fact, there is kind of a broader debate that this fits into, which is whether health insurance actually improves health and lowers mortality. And you might think that the answer is obviously yes, but in fact, the evidence in support of that is more ambiguous than one would like. So there's two very famous experiments that were conducted, the RAND health insurance experiment and more recently, the Oregon experiment. And the RAND health insurance experiment, which took place in the 70s, gave people health insurance for 3 to 5 years. The primary purpose of that was to look at how that affected healthcare expenditures and utilization, but they also measured health, and they did not find increases in health among those that had more generous health insurance plans. They did find that if you were poor and had chronic conditions, then there were some signs that you might have benefited from the insurance, but despite the fact it took place over 5 years, there were no meaningful average improvements in health. There's another experiment that took place more recently in Oregon, where individuals were randomly assigned into getting access to Medicaid. And so this was only among individuals who were poor. They were followed for 2 years, and there were some improvements in self-reported depression and in health, but not in objective measures of health. And neither of these programs were powered to look at mortality impacts, and they focus on prime age populations, young populations among whom mortality is low. And so it's not clear that they could see anything. And there's a recent experiment sending the IRS sent incentives for people to pick up Medicaid insurance, so again, among the poor, and they did find some suggestive evidence of improvements. So this is the experimental evidence, and there is a larger quasi-experimental evidence, meaning it's not a randomized controlled trial, but people look at data and they try to approximate the ideal experiment using observational data. And there's been a lot of work looking specifically at Medicaid. And the reason for that is that Medicaid is a program that has a lot of variation across states and a lot of variation over time. So Medicaid is a program that provides health insurance to the poor, and it has seen many variations over time, and people have exploited that to see whether, for example, recent expansions of Medicaid during the Obamacare health insurance expansions affected health. And they find that Medicaid lowers mortality for poor children, both in the short run and the long run. The evidence for adults is a little more mixed, but they tend to also find improvements. So I think it's fair to say, summarizing this evidence, that there is support for the idea that health insurance helps poor individuals in particular, and in particular if they also happen to be unhealthy, but most of this evidence actually does not cover the elderly. So moving on, what do we know about Medicare? Well, there is also limited and ambiguous evidence for Medicare. Medicare is a much more difficult program to study because it's a federal program. It was introduced in 1965. There have been only a few changes to it, and it applies equally to all states and people. And so it's substantially harder if you don't have an experiment to understand what its effects are. And I think because of that, the evidence is more limited. So there are some papers that have tried to look at that. Card in 2009 has a very famous paper now, where they look at the in-hospital mortality of individuals that show up at the hospital with urgent hospital admissions during the weekends. And they find that if you are over 65, you do better than if you're under 65. So this is a kind of a small subset of the Medicare population that shows up. And they're only looking at in-hospital mortality. There's also a paper that looked at one of the expansions of Medicare that took place in recent years, which was the introduction of prescription drug benefits. And so this paper finds that it lowered cardiovascular mortality at age 66 by increasing drug expenditure among people who are near poor. So again, here you see something somewhat similar to what you see in the overall literature, which is that if you focus on people that are sick and poor, then you find effects. But then if you look at the overall population, Hard and these other people by Polsky, it turns out it's very difficult to detect any decline in mortality at age 65 exactly among the overall population. And interestingly enough, the paper that might be closest to the one we're studying here today is a paper by Amy Finkelstein and McKnight, who looked at the introduction of Medicare and looked to see whether mortality rates of the people 65 to 74 fell in comparison to the mortality rates of people 55 and 66 to 54. And they found that the answer was no, that there were no impacts on mortality. And so this is where we are. Maybe there's some impacts for poor and chronically ill individuals. Maybe there's no impact overall. None of this work really considers the long-term impacts of health insurance. And so even though some of these studies look over 3, maybe 5 years, the study actually goes all the way up to 10 years. There's some evidence to, there's some reasons to still be concerned that they don't capture the potential full benefits of these effects. And so, you know, when you have health insurance, you might have a lot of preventive care, the benefits of which may not materialize for many years. And in fact, you can look at evidence from the medical literature that suggests that impacts on mortality will take a long time to materialize. So just to give you one example, this is a randomized clinical trial of a set of interventions that were designed to lower cardiovascular disease mortality. And they did so by using everything at their disposal to address this. So drugs to lower cholesterol, drugs to lower hypertension, changes in diet, changes in exercise, constant supervision, etc. And they find immediate impacts on health and immediate impacts also on earnings. But when you look at mortality declines, it takes like about 10 years for mortality to start showing decreases in this population, despite the fact that other markers actually do show improvements. And so for this reason, I think, you know, it's important to try to understand over the long term what is happening. So we're going to try to do this in this paper, by summarizing these, we're going to look at what happens at mortality, and we're going to summarize everything by seeing what's the impact on life expectancy. So in the paper, we're going to look at these new individual data that we have. So part of the limitation in a lot of this work is that it's very difficult to obtain data. So in addition to not having a lot of variation to study this program, we don't have very good data. So the data that this paper used was aggregated data in 10-year bins, because that's what was available. Not the most awesome data for a demographer. So we have these new individual data. I'll tell you more about it. We essentially start with the 1940 census, where we have individuals and we know who they are, we know their names, and we match that data to family trees from Family Search, and these are genealogical databases. We obtain a database of about 18 million individuals that we can follow from 1940 all the way until they die, and I'll tell you how we're going to use this data. Identification, or kind of trying to estimate what the causal impacts of these programs is going to the core of the paper, and it's very difficult. So we're going to use 3 different ways to assess this, and I'm going to go into this, and I'll come back at the end to think about why our results are different from the ones in the literature, if there are. And the main contribution of this paper is to provide these estimates. As far as I'm aware of, there are no estimates of the effect of Medicare on life expectancy. We're going to look at life expectancy at age 65. And because we have this rich individual data, I'm also going to give you report heterogeneity by cohort, which is going to be important because different cohorts became eligible for Medicare at different ages, and by socioeconomic status. So we are able to observe income, education, occupation in the 1940 census, so we can use that. I'm not going to show you anything by race, and I'll talk about that, or geography today, because the paper is already kind of monstrous as it is. But we're getting there, so if you want to see this, it is coming in future work. And it is very important, but there are some challenges, particularly by race. So the preview results, in case you have to leave early, we find a large and statistically significant increase in life expectancy of about 1 year for men. And this is averaging across cohorts born 1885 to 1915. If we focus on the cohorts that got Medicare at age 65, then that number is closer to 2. The thing that's interesting about this also is that it helps us understand the literature, is that when you look at mortality rates, you see effects on mortality rates that are small, essentially 0 in the first year, and they grow, and then they stabilize after that. And so that's one of the contributions that we can see. But essentially, if you were thinking about doing a difference or a before after, just looking at 1 year after, you wouldn't find much, and we don't find much either. So really, it's the long term that becomes really critical here for understanding these effects, and I'll show you. Now these as all for men, and unfortunately, you will see our results for women are really inconsistent. So I don't want to say that there aren't effects of Medicare for women. I just want to say we cannot conclude from the evidence in this paper whether there are or aren't large effects, and I'll try to discuss that. And the other thing that's interesting here is that when you look at mortality rates, previous works, let's try to separate high and low ACS individuals, thinking that low ACS individuals benefit more because they're less likely to have private health insurance before or even contemporaneously, and they're in worse health. And when you look at health measures, you tend to find utilization increases more for low-income individuals, consistent with that hypothesis. However, what we're going to find is similar life expectancy gains by education and income, and I'll talk a little bit about why that is. Okay, so historical background. Medicare was passed in 1965 at the same time as Medicaid, so I'll come back to that in a moment. It was passed by President Johnson, who declared no longer will older Americans who denied the healing miracle of modern medicine. I want to emphasize that at the time, and for many of these programs, even though we as demographers saying, oh, this is all about health, this was all about money. This was about how much money people were spending out of pocket, and then trying to not get them to be broke in old age, paying for this. So there's a benefit of Medicare, just going back to this question, I want to be very clear about this. There is a financial insurance benefit associated with insurance, and that benefit is pretty large. And the work of Amy Finkelstein has tried to quantify what is the economic benefit that comes from insuring their consumption. And so there is one benefit to Medicare that I'm not talking about, which is on your pocketbook, and that's large. And that was an important objective of the reform. And in that sense, the reform was very successful. Of course, the whole point of allowing you to be able to access and healthcare was that you would live longer. So that's what we're kind of looking at here. Was that also true? Importantly, almost everybody over 65 who is in American soil is eligible for this. There's some caveats to that, but really for the purposes of this talk, think of everybody being eligible at age 65. In 1972, individuals under 65 with long-term disabilities or end-stage renal disease also became eligible, and I'll talk a little bit about this because it might affect some of what we're doing. And so I want to, before I go into mortality or anything else, you might say, well, did anything happen immediately after the passage of this? And other people have done this, so what I'm about to show you isn't new. Medicare improved health insurance coverage. So this is a figure that we did with the National Health Insurance Interview Survey. So here on the left, we have the 1963 survey. This is a nationally representative survey of the population, the non-institutionalized population. And so this is the fraction of people who have health insurance coverage. So almost at this time, what it meant of health insurance was primarily hospital insurance. Almost nobody was insured for anything else. And so this is the question that's asked in the survey: do you have hospital insurance coverage? And you can see that by age, for the white population, this hovers around 70 to 80%. But prior to passage of Medicaid, that share fell very substantially with age. So people became impoverished and they also retired and they did not have access to health insurance anymore. You can see kind of for reference, although again, I'm not going to be able to speak about race today, that these insurance rates were much lower among Blacks and also very, very low after age 65. And so here you can see 1968, which is, so I should say the law was passed in 65, but the program was implemented first in 1966. So this is 2 years after its implementation. So fairly quickly, you can kind of see the success of this program. The insurance rates among whites are like above 90%, and you can see that they don't fall with age at all. And there's also a big increase among Blacks that compared to the pre-period, there's a tremendous increase in the fraction of people who are covered. And I should have the figure, but I don't have it yet, that if you break this by SES, it would be similar. If you break it by education or income, the biggest increases compared to the pre-period would be for uneducated or low-income individuals. So the other thing about this is like, okay, well, maybe everybody says that they have health insurance because there was a law passed, but are they actually accessing anything and using more healthcare? And the answer is yes. Now that's very difficult to establish because there's not a lot of very good data on this. So we collated data here from a lot of different surveys, and the issue is that there's not a lot of data going back in time. And so I'm not going to bore you with what all of this means. The only thing that I want you to see is the gray markers over here show the under 65 population, and the outcome here is the hospital days per person. So if you look here at the gray markers, you see that the average hospital days per person is kind of fairly flat here from 1935 all the way to 1975. For the over 65 population, they are very similar right up to the time before this passage, and then it kind of goes up. Yes.
Clarification question. You, as you noted, Medicaid was signed at the same time.
Yes.
So Wouldn't we see a Medicaid effect in the under 65
Maybe.
population?
Maybe, I mean, you can try to look at it here, right? And so like, you can look at and see where do you see that for the under 65 population? And it's not so clear to me. There's an increase, but the Medicaid is only for people. So when Medicaid was passed, it was only for people who were eligible for welfare. And who's eligible for welfare there? Single mothers with children under the federal poverty line. So it is a subset of the population here. But you can see that at the population level, it's kind of hard to see that it's making like a dent. But if you're narrowing on those populations, you would see it. I think you see it maybe among children a little bit, but it's not visible from this figure, at least not yet. But we'll come back to that. Okay, so I think this is well understood that insurance rates went up and utilization went up, and this is just showing you what other people have shown, but in just some figures. So what are we gonna do? Okay, we're gonna take two data sets and try to estimate effects on mortality. So let's quickly tell you about this. The first data source has been available for a while, but it's provided by the Social Security Administration. The Social Security Administration recently published newly generated cohort tables, both period and cohort tables starting from 1900 onwards. These tables are based in the first 35 years are based on incomplete data from the vital registration system in the United States. And so for these early cohorts that we're interested in, these data is not originally coming from nationally representative data. They reweigh it to be nationally representative. The data is only available by sex at the nation level. It's not broken down by race, socioeconomic status, or geography. But we're still going to use that. We're going to consider this kind of the gold standard because that's what people use these days. The alternative data is the one I was describing, where we match the 1940 census to family trees. And so let me tell you a little bit about this. So these are genealogical data. Individuals go into a website, they create a family tree, they say, this is my parent, these are my parents, my grandparents, it's my spouse, these are my children. And in doing so, they also report the date of birth, the date of marriage, and the date of death. They also report the location where those things happen, and that's it. Now, in this database, when you create these trees, individuals are also allowed to attach data sources. So if you have a birth certificate, a death certificate, a tombstone, anything, you can attach it there. So you can tell whether a tree is high quality or low quality by whether or not there are a lot of additional sources that are consistent with the information that is reported in the tree. So even though this is reported and created by individuals, there are ways to verify that this data is accurate. One of the benefits of this is this comes from multiple sources, not just official vital registration states. So it has death information, birth and death information for many more people than what the Social Security database is actually using. Now, the question is that data good? So we'll come back to that. And the 1940 census provides this demographic. We are going to restrict attention to white native-born individuals born between 1885 and 1915 who survived to 1940. And why is that? So Black populations and immigrant populations are very underrepresented in genealogy. So we currently have a grant, or had a grant, hope to have continuing grants to study this, okay? And so the reason that I hesitate on showing even any statistics on this is that while we can match between 30 to 50%, sometimes even 70% of white populations, depending on who we're looking at, the match rates for the Black population are in the order of 3%. So I've studied this in another paper, but they're extremely selected. And so that's very important to keep in mind. And so I'm not presenting results because we're hoping to improve their representation to do a better job here. And immigrant populations are also very disproportionately underrepresented in the tree. So we're focusing on the native white population for now. So we start with the census. There were about 135 million people alive. If you link that to all the genealogies, you get about 49 million people. If we restrict to these cohorts, you get 24 million people. Then we look only at people who have valid death data, and that gets us about our 18 million people. And what I'm gonna show you today, so Bacon, one of my co-authors, is very interested in this. He wants us to work with the training sample, create a p-analysis plan, and then eventually use the full data. So I'm not going to show you the results with 18 million people, but with about 2 to 3 million people, because we're doing all of the analysis now. Okay, so how does this data look? Well, if you just look at the raw data, you'll see that places, so this is in blue, like the Northeast is underrepresented compared to the South and the Midwest. And the same is true when you look at regions of birth. We just used the 1940 census to create weight to make this more nationally representative. And then that's the orange line over here. And you can see that once we do that, the data is much closer to nationally represented. We do fairly well with women, but women are still slightly underrepresented in the genealogies. And so we adjust for that too. So the weights adjust from the fact that not everybody's matched, and so we're trying to our best to kind of make it representative, but still only of the white native population. Is this data good? So here I'm showing you for the cohorts for which we have Social Security data, I'm showing you the cohort mortality rates from the Social Security Administration and the implied mortality dates in our data. And so you can see that, you know, it looks really good. It behaves the same way. And there's just a slight difference in the levels where the mortality rates in our database are always lower than in the Social Security data. And in fact, if you compute the life expectancy at each point, you'll see that we are between 1 and 2 years higher. And that's in part because we don't have immigrants, we don't have Black populations, we also don't have people who come from small families are underrepresented. So there's still some representation issues. Note, by the way, that the SSA is also not clearly representative itself, but I think the two databases at the aggregate are very similar. And so we're gonna take this as evidence that the data is pretty good, at least at the aggregate level. So before going on, I'm gonna talk about how should we think about Medicare affecting mortality. And to do that, I'm going to show you a model that I wrote in another paper very quickly to make some predictions, and also because I'm going to use the model for estimation. So bear with me here for a second. So do you agree the data is good? Now we're going to move into estimation. How do we predict the possible effects of Medicare? And I'm going to do that with a model that we wrote that's a very simple model, and let me tell you how it works. We're going to assume that the population is born with a particular health, and that health is normally distributed. And then thereafter, the population health evolves according to this process where whatever health you have in the first period, it deteriorates. And so this is an aging function over here, and it deteriorates at an increasing rate with time. If this coefficient is greater than 1. But you can invest in your health, and so you receive resources from the environment, food, etc. And that allows you to improve your health potentially. So I'm going to call that an investment. But there are also shocks. And these shocks I'm going to assume are normally distributed. So the way to think about this is you live in a given place, there's an average amount of food, but at any point in time, some farmer has a better crop than another farmer, and so they have like a more positive or a less positive shock. And this shock is going to be assumed here to be mean zero with some standard deviation. It's also going to be assumed to be 1. And so then what happens is that an individual will die if their health falls below a certain threshold. And so that in here means that individuals who are less healthy are going to be the first ones to die. But you will also die if you are unlucky and a piano falls on your head when you're walking on the street. So there's going to be an accident rate kappa that is independent of your health and your age. Of course, the other way that you die in this model is that maybe you're not unhealthy, but you receive a very negative shock. And so there's going to be kind of three types of people that are dying. Unlucky people who for some arbitrary reason have an accident, people who are in good health and are very unlucky, they get very sick and they die, and people who are in bad health and essentially either because they're aging or they get a very small shock, they also will die. So you can think of the environment determining kind of the average resources that people have and the shocks. And then there is an underlying aging process that is getting people to be less healthy over time, kind of perhaps independently of this. And then there's this accident risk. This model was developed to describe populations in stationary environments. And so it's not going to be perfect for what we're going to do, but let me tell you how it works. So we start here with the blue distribution, which is the health of people at birth. If the investment is larger than delta in the first period, then the distribution is going to move up because we have added positive resources to the person, but there's a shock, so the distribution gets wider. And so the infant mortality or the mortality in the first period is going to be the area under this dashed curve. And so that's mortality in the first period. So then what happens in the next period? Okay, so again, in the next period, if I is sufficiently large, all this distribution is now to the right of the threshold. So nobody would die except we have these shocks. We have people who get a health shock, and some of them are going to fall below the threshold again. And so there's a negative health shock, some people die. There's also accidents that get people to die. And so in every period, you're going to have people dying who fall below the threshold or people dying because of accidents. And that over time, health evolves this way. You know, you'll have babies and they're born very relatively close to the threshold. That's primarily what determines infant mortality. And their distribution is not that wide, but the distribution of health kind of increases over time and widens, and then eventually the aging process takes over and it starts to move closer and closer to the threshold. So here we have the 90 years old. They are kind of as healthy as newborn babies, except for the fact that there are a lot of 90-year-olds that are very, very healthy compared to babies. They're not nearly as fair. That's what's happening in this. Why am I using this model? Okay. Well, this model has a few parameters over here. These initial health parameters, the aging parameters, the shocks, and the accident rate. And with these 5 parameters, we can actually do a fairly good job at describing the evolution of mortality for populations in stationary environments. So in the previous paper, we fit this data to chimpanzees, and we fit this data to all the birth cohorts born in France between 1816 and 1940. And what you see is that you do a great job until about the 1900s. So I'll come back to that. And here you can kind of see what's happening. You have kind of 4 periods in this model. Your initial conditions at birth, and then you have a period of childhood where mortality is falling very steeply, and then you have the adolescent hump or adolescence and young adulthood. In the model, this is fit because that's when we turn on the accident rate. So I didn't kind of tell you that detail, but we assume that accidents are kind of 0, and then they're like a positive number thereafter. And you can see that that fits the data fairly well here. And then at some point, you know, mortality starts rising pretty much linearly, which was what Gompertz observed in 1825, and the model matches that fairly well as much. So if you only had data on adults and you looked here, you could see the Gompertz-Mackenham law, which is there's a age-independent level of mortality, and then there's like mortality growing linearly with age thereafter. And so the model does a good job of fitting this, but it also does a good job of, you know, explaining differences in SES, how in utero conditions will vary, or how shocks will do that. And the way that we think about that in this model is to say, well, okay, but where's behavior? how do we think about things happening and changing the mortality of these populations? Well, we can imagine things that change the initial conditions. So what happens if we change that parameter? We can imagine changing the way we invest in our health, so changing this parameter. Maybe we can imagine changing aging rates. And that's the exercise that I'm going to do right now to predict the effects of Medicare. So what I'm going to do is I'm going to take parameters here from these French cohorts, and I'm going to tell you, let's imagine something happens at age 65. What does the model predict? So the model predicts that if you increase I, this investment, mortality rates will fall. But notice what's happening is almost nothing happening immediately. And then there's like a rotation of the slope. If you change the parameters of the aging process, you get a very similar phenomenon where you get very small effect at first, but then again, you get a rotation of the slope. And then kind of two other things that can happen. So you can imagine when Medicare is, it's an insurance program. And what is insurance? You pay a premium in good times, and then you get money back in bad times. So that's equivalent to decreasing the variance of the shock. And if you do that, you would see an immediate decline in mortality and an increase in the slope. And eventually, the mortality rate would be higher than in the counterfactual because there'd be some people who used to have very positive shocks, but now when they do, they're transferring that away to their bad states, and so they do worse. And the final thing you can imagine Medicare doing is, so, this is like, I give you money every period, and that improves your health. This is like Medicare does prevention, and it slows the rate of aging. Medicare is insurance, it transfers resources from good to bad. This would be what Medicare allows you to do is that, you get to the hospital, and instead of dying, they plug you to a lot of machines and they keep you alive. And so they change the threshold for dying. So instead of dying at some particular point, you're now going to be kept alive. And if that's true, then you see a very large decrease in mortality and then an increase thereafter. So to a first order approximation then, what this prediction of the model says is that we can characterize the change by a change in the intercept and a change in the slope. So in these two cases, the intercept change will be 0 and the slope will be smaller. And in these two cases, the intercept will fall and the slope will be higher. And that's one of the things we're going to use for identification. So if I just now plot the difference in these two curves, kind of like imagining what an event study might look like. So this is all a simulation. This is kind of what we expect the path of mortality to look like in each of these cases. So we're going to look for these signatures in the data. So we're going to do 3 identification strategies. One is just estimate the model. Estimate the model up to age 65 for each cohort. Predict mortality compared to counterfactual mortality. Interrupted type series here is to say this is linear, but does the slope and the intercept change? And the last is a difference in difference design. And let me just walk you through that. So let me just skip this for a second and just go here. So now I'm showing you kind of how this would work for the 1900 birth cohort. And so I estimate the model to fit life expectancy up to age 65. And here you can see how well the model does and how poorly it does. It matches mortality rate here very well, and it matches mortality rates here well. It does not match this particularly well, but the important thing to remember is that this is plotted in logs of mortality. There are in fact very few people dying here. And so even though we don't do so well, this has very minor implications for life expectancy. So then what we do, the first way that we generate this life expectancy is this is what the model predicts, but this is what the actual data looks like. So the difference between these two gives us the implied treatment effects, and we can now kind of compute life expectancy. So there's a few assumptions that we're making here. This assumes that there's no anticipation, that people don't start changing their behavior before they're eligible. Obviously, it also assumes that the model's right. And it has a big limitation, which is that to fit this model that has 5 parameters, we really need data from birth to death. Okay, so we're going to be able to do that with Social Security Administration, but not with our data. It also, has this problem that, like, how well do you fit this particular shocks matters. And so that's gonna be an issue. So the second way we're gonna do this is to say, okay, well, let's just focus on the old people. I'm gonna count myself as old here. You know, starting around age 40, here you can see for men, this is pretty linear. This is the Gompertz observation. And so we're gonna say restrict attention to this part over here, and then just estimate what I said before to a first order approximation. We can say these are two lines and what happens to them. So here's an example here for the 1895 cohort. We estimate the line before, and then we project out, and then we estimate the line after. And so now this again gives us the path of what mortality rates that the event study. And we can also characterize this as a change in the intercept and the slope. And as you can kind of already see here from these examples, you know, we're not really going to find much of a change in the intercept, but we're going to find a change, a decrease in the slope. And you can see here that for women, for this particular cohort, you can already see we find nothing. And it's the same approach. Now the issue with this approach is, okay, we also need to assume no anticipation, and I'll come back to that later. The issue with this approach is if you're paying attention here is that mortality is not linear, not log linear all throughout the lifetime. It starts being linear at some particular point. And what point is that? And what if we start the data here and we fit a line, we're going to get it wrong. And so there's this issue of like, when can we make this assumption? And what we're going to do is we're going to do it two ways. We're going to take a 10-year window before and after around 65. And then alternatively, we're going to estimate the age at which this starts becoming linear and use that as the window. But that's kind of going to be important. So because we're limiting the window, we're only going to go up to 10 years. Okay, so then maybe you say this is crazy because this is just like one cohort. What if other things happened to this one cohort that affected their mortality rates? You're calling this Medicare, right? Okay, so maybe we don't like these first two methods because they rely on our ability to estimate this within that cohort perfectly, and they assume that everything that happens afterwards is just Medicare. So what else are we going to do? We're going to think about doing a difference in difference approach. And that's going to be a slightly different idea. And so what we're going to say is like, okay, so focus on this cohort, the 1895 cohort, same one we're looking at before, and say, okay, well, what's the effect in the mortality in the first year? Well, that's the change from age 64 to 65 in the mortality rate. So that's this increase over here. And how can we create a counterfactual? Well, let's go to the cohort before, and let's look at the change in mortality from age 64 to 65 for them 1 year before. They weren't eligible for Medicare yet. And so this provides our counterfactual. So now you can say, okay, but why did you only choose this cohort over here? You can go back in time many cohorts, and you can. So you can create the counterfactual for this using many of these 1 year changes going back. Now, what's the assumption? The assumption you can see here is that in the absence of this change, this would provide a good approximation, which you can judge by seeing whether or not the lines were parallel before. So one way to decide how many cohorts to include is to check and see whether the counterfactual mortalities before implementation of before eligibility are similar. Now, that only gives us the 1 year mortality. So what about the 10-year mortality, since we're interested in long term? Well, now this is the 10-year mortality change for this cohort. And now you go back in time and find the cohort for whom you can observe the change in mortality at the same age as before Medicare passed. So that means you have to go back in time here 10 years. And so the downside of this is you might say that's kind of crazy because this cohort is actually much older. But in this approach, this is the only way to get the long-term thing. So there's this trade-off here that the longer we want to estimate these treatment effects, the farther back in time we have to go. So we're going to use 10 years, or we're going to use a test to see at which point this breaks down. Okay, so results. So here are the reduced form results. There were two, the change in slope and intercept, or the difference in difference. And if we average across all cohorts, this is what we find for males. So there is no evidence that there are differences in the pre-period. and there's a decline in mortality thereafter. And you can see that both methods, whether we use the comparison cohorts or whether we just look at within cohort, give us very similar impacts. You can see there's like no effect at the beginning, no statistical significant effect within 1 or 2 years, and then a growing effect thereafter. You can see the problem that we have for women here, which is that one approach gives us positive and statistically insignificant effects. The other one gives mostly statistically insignificant effects of the opposite sign. So we're getting pretty different results with these two methods, and they're mostly statistically insignificant. Now, these standard errors are not that small, so this doesn't rule out large positive or large negative effects for women. If we instead do the structural model that I was talking about, estimated up to 65, and then compare it to what happens after 65, this is what we get. And so we get very large declines for men, and then they stabilize. We also get very large declines for women. So if we put it kind of all together, the three methods, kind of what do we see? The three methods for men agree perfectly. There is a close to linear decrease of about the same magnitude. I say about because of standard errors here. And then with the structural measure, we can go beyond this kind of stabilizes. And for women, we can see pretty much, positive, insignificant, negative, insignificant, and pretty large and significant. So that's kind of going to be the problem for women here. And so we're trying to work on why this is the case. So let me tell you, like, if we can characterize this in terms of intercepts and slopes. And so we pretty much all the methods agree that the slope for men falls. There is very small and mostly statistically insignificant changes in the intercept. And again, for women, you can see this is kind of all over the place. So the punchline, finally, the implied effects on life expectancy that we get here at age 65, this is what they are cohort by cohort. These are rising. They're very small for these cohorts. This cohort becomes eligible. So if you're 1890 in 1966, you're 76. And so these cohorts are old. So for the cohorts that get into Medicaid at older ages, the effect is small. And then it grows. And so the 1901 cohort is the one that gets it at age 65. And for these cohorts, the effect is around 2 years of age. And then there's kind of a decrease and a kind of a disagreement among the methods for the more recent cohorts. And here you can kind of see the disaster for women, which is that the thing is really all over the place. So that's what we have. Now I don't have a lot of time, so I can talk a little bit about women, but I want to show you just before I stop because I'm running out of time, just the results by income. So we want to do things by income and education for two reasons at least. One is that, we're assuming that these parameters or these estimates are the same for everyone, which may be crazy. So it was already pointed out maybe before how different evolution. So this relaxes our identification assumptions, but of course there's a lot of other reasons to think the effects are different, but it's not clear how that would go. On the one hand, the more educated and rich are more likely to have insurance. So you might think they have a lower benefit. On the other hand, among people with insurance, the educated and rich actually use healthcare more and are more likely to use newer technologies. So they might actually benefit more. So based on the literature, it's kind of not clear. It's also interesting that if you look at the model gives ambiguous predictions, and this is something I hadn't appreciated before. It's not true about our model, it's just true in general, that the populations that have the bigger mortality increases are not necessarily the ones that have the biggest increases in life expectancy. And that's just a fact of how life expectancy works that I never appreciated before. So if you just look at the mortality rates by schooling, for example, you see kind of maybe bigger declines for the smaller schooling levels, or that's not so clear to me. You can see that for women who just continue to do poorly no matter what, and it's primarily zero results. If we do things by income, again, they look to me very similar. And if you just look at the levels here, there might be even larger for the high income compared to the low income. And again, nothing consistent for women. So if we put it all together in a table and go across all the cohorts, the average life expectancy across the two reduced form methods would be between 1 and 1.1 years of life for women. You can see that for men, one method says the more educated gain less, the other method says it's about the same. And if you look at these confidence intervals, you could never reject that these things are in fact identical. And you get very similar patterns here by income. You cannot separate, even though these income groups are actually widely different. So in the 1940 census, it's about 10 times more income on average above the median than below. And here you can see, again, for women, the very inconsistent results, which are negative or positive, and then they have opposite patterns and also are mostly insignificant. So I have a lot of threats of identification. I know people are going to ask me about this, but maybe just let me comment for 1 second. These magnitudes, are they reasonable or not? Life expectancy at age 65 rose by about 1.5 years and 2 years for women for these cohorts. So this would kind of say that for Medicare, for men, Medicare can explain pretty much the entire rise in this region. And you can also say, is this reasonable? So we're trying to look at how does this compare to other interventions. So if you give poor kids money when they're growing up, their life expectancy increases by about 1.5 years. If you give young men training during the Great Depression, their life expectancy increases for about a year. If you look at clinical trials of cardiovascular interventions, those increase life expectancy by multiple years. So it's not unthinkable. One thing that I will say is I have computed some magnitudes of this. This suggests it's possible to increase life expectancy for elderly individuals just as much as it is for young individuals. However, the cost is much larger. And so if you compute what this costs or this costs per year of life, Medicare actually costs more for the same increase in. Let me just stop there because I think I'm wildly over time, and thank you.